Ali Hassan and Mark Chambers. You're all extremely welcome as members of the board. Sally Cheshire is also a new member of our board. As is often the case when people join boards with fixed engagements, Sally is actually chairing another meeting somewhere else today, so it can't be with us for this particular meeting, although she was with us earlier. So really, really good to see you. And actually, did I mention you, Ali? If I didn't, I apologise. Ali Hassan is also with us, so that's great. So I hope I've not missed anybody out. And apart from Sally, we have no apologies for absence. Does anybody need to declare any interest that's not otherwise on the list of interests? Excellent. And then that takes us to the minutes of the December meeting. For those that were on the board at that time, are they a true and accurate record of what we discussed?
Yes.
Excellent, thank you. So they are approved. For the first time that I can remember in the 5 years I've been chairing the board, there is absolutely nothing on our action log, but that does not mean there's not lots of action. It just means there's nothing that's come forward from the last meeting. Was there anything arising that's not otherwise on the agenda or on the action log that anybody wanted to raise?
Peter, could I just draw people's attention to page 5, para 19, reference to laying of our accounts. Just as a point of good order, really. We've still not been able to lay our accounts from 2019-20, as the National Audit Office have not been able to obtain the assurances they need from the local government pension schemes. This relates purely to issues of workload on local government auditors rather than anything to do with materiality, as far as we are aware. So this is a COVID issue rather than anything else. So in every other respect, our accounts are ready to lay, but I just wanted to sort of again just make the point, which I know we've been making in previous board reports, that our accounts are not yet laid, but they are ready to be laid, and it has been raised, of course, with the NAO and the Department of Health and Social Care. Thanks, Pete.
No, thank you. It's really frustrating, but it has absolutely no impact on us. I mean, our financial position is not impacted by this delay. It's just a procedure thing.
Just to update, Peter, just while we've been on the call this morning, I think we've had the green light through to get them to the signing off and certification. So hopefully we can finally get that progressed and update the board next month.
Oh, perfect. Good. So I said there was lots of things going on, even if there's nothing in the action log. I didn't realise, Chris, you were actually doing that as well. Perfect. Good. So we look forward to a different story next month. Perfect. Thank you. Right. So, Ian, shall we move then on to the executive team report, please?
Thanks, Peter. So this month, we've decided to split the executive team report into two parts, just for clarity, really. I think I want to spend a few minutes just talking with the board around our priorities at the moment, and then the second part of the report will be other things that are not related to priorities. And the reason I wanted to do this is because do it in this way is because I think we want to be really clear about what we're doing and indeed not doing during the next 3 months. So really what we want to do is to say quite publicly and quite clearly that around what our priorities are for the first quarter of calendar year 2021. I want to begin really though by acknowledging the absolutely superb work that's being done right across health and social care, whether that's people that have been coming to work every single day and doing a fantastic job and not really being seen, whether it's the teams that are working on vaccination programs, the teams that are running intensive care units and so forth, and the teams that people don't often talk about that make sure that patients get where they need to get to in a hospital. There's just a fantastic range of people, and I think we as the regulator want to acknowledge that, and I think whilst there are undoubtedly grounds for optimism with an accelerating vaccination program, I think the people working in health and social care at the moment have been under sustained pressure for well over a year. there was a busy winter that rolled straight into busy COVID period. So people will have been working incredibly hard for 14, 15 months now, and that takes its toll. I think we can all recognise that if we have a busy day or a busy week, then it's we can manage that. But doing that for months on end has been hard, and it's been hard for our own teams as well. But I think we need to start, our discussion this morning from that perspective. And all the way through the pandemic, we've attempted to be as flexible as we can be, recognising the fantastic work that's going on in the health and social care system, and balancing that with our duty to provide the public with assurance around the safety of the health and social care that they've got. And I think that balance of respect for people working in the system and our duties around the public has been something which has dominated our thinking right from the very start of the pandemic. So we paused our inspections, as you recall, right at the start of the pandemic, but we've never stopped regulating, and that has been an important message all the way through. We've just looked for different ways of doing that. And this meant that we've looked for different ways. Some of that's about increasing the amount of off-site work that we do. Some of that's about the work that we do on-site, but doing that in different ways. And some of that's been about blending those two approaches. We, of course, have kept our approach under constant review as events have unfolded, and we went from trying to use our existing methodology through to the emergency support framework, through to our transitional methodology, which we introduced in the autumn of last year. And as part of that constant review process, we've been reflecting on where the health and social care sectors are right at the moment, and of course things have got incredibly busy over the last few months. So we've decided that for the first quarter of 2021, we'll group our work into three broad categories, and those categories are aimed at either adding capacity or responding to risk in the system. So either adding capacity or responding to risk, and there's an important sort of, if you like, headline focus for the work that we've been doing. Our work then is in three categories, which is proactive, reactive, and supportive. So in the proactive is all about planned pieces of work in areas such as infection prevention and control, or areas where we know that we have specific risks, specific and long-standing risks. The reactive work is about exactly that. It's about reacting to information that we have from the public or from people that work in services. And the aim there is to look for ways to bring other partners in to support services which are struggling, to highlight those areas that need particular support. And there are plenty of examples of us doing that. And the third category of work is what I describe as supportive work where we're working with other agencies and other organisations, people like the Department of Health and Social Care, NHS England Improvement, and others, so that we can help with things like accelerating the vaccination programme or on policy development in areas where we perhaps have a unique perspective that we can bring to the table. And it very much is about making changes as we go and responding to the nature of the particular issues of the day, and particularly recognising that the health and social care system at a macro level is busy, but it is even busier in certain geographies. And we've seen over the last couple of weeks, particular challenges in London. But of course, we'd expect that over the next few weeks rather, that those challenges will move geographically around the country as things begin to quieten down in London. So I'm going to ask Kate, Ted, Rosie, and Kirsty in that order, just to give a flavour to board members of the work that they're doing in their areas to support this agenda of proactive, reactive, and supportive, and to give some specific examples. And I think that just before I hand over to Kate, I just sort of make the point that the sort of, which I think is unspoken in some respects, but I'm going to say it anyway, is that this the idea that we're prioritising some work by definition means we're not doing other work, and so there is inevitably going to be a degree of risk in the system that we perhaps aren't able to see. We're using all of our means to look for that risk, but I think we have to recognise that that's the place that we're in. It also means we're explicitly not doing certain things. So we're not doing reviewing of ratings. It was a topic that we've been thinking about. How do we restart our ratings activity? Because many providers are overdue a rating, and we've not been able to do it. We don't think that we can do any ratings reviews in the next few months. We're also going to do less of our transitional methodology, less of our contacting people proactively. We're going to be just pausing our provider collaboration review program and pausing our provider information returns in adult social care. We will, of course, continue to promote our Give Feedback on Care service to gather information, and of course we'll continue to publish important information on a monthly basis, and you'll see our Inside Report is later on the agenda today, and we will continue to use that as a vehicle to talk to the public and keep the public up to date in terms of what we're seeing in terms of data. So I'm going to pause there, Peter, and pass over to Kate for her to talk about what she's doing in her area. Thanks, Kate.
Thank you, Ian. So I'm going to talk about what we're doing in adult social care in the proactive and reactive groups of work that Ian has described. So firstly, in proactive, we are continuing our focus on infection prevention control inspections in care homes. We've done a vast number of these since the start of the pandemic. We committed, following conversations with government, to increase our number of IPC care home inspections during December and January to 1,200. We've done 900 of those, and 286 are booked in for the end of January. That number is likely to increase slightly as well as we respond to risk. So we're on track on delivering our increased offer around IPC inspections at care homes, and we've committed going forward through February, March, April to do 600 of these in each of those months. We are being assisted in our efforts in adult social care by 43 inspectors from primary medical services who are coming across to help with these efforts as well. They were trained last week and they have started inspecting this week, so a big thank you to Rosie and to all those colleagues for helping us with that work. So we are supporting the increase in capacity in the system, noting the significant pressures that are being experienced by hospitals at the moment through our ongoing rapid response to potential designation schemes. So these are government initiative where if people have been tested COVID positive within hospital and their long-term plan of discharge is to a care home, they should not be discharged directly into a care home, but they should be able to go into a designated setting during that 14-day period. Local authorities identify these potential schemes. The information gets sent to us. We check that the provider is aware that they've been nominated, and we go out and inspect within 48 hours. And we are consistently responding to those requests within that agreed time frame. To date, 135 designation schemes have been approved, and we are ready to respond to potential increased demand following the government's announcement about insurance 2 evenings ago. We are also looking at whether we can support around increasing capacity to enable people to leave hospital in a timely way when it comes to re-rating some services. So many commissioners will only commission new packages of care from services that are rated good or outstanding. We are going to be looking at inadequate or requires improvement home care providers or care homes where there is some evidence to suggest if we were to go out and re-rate, that rating may improve. We are planning on going out and doing those inspections, re-rating where appropriate, and then potentially opening up capacity for new services that commissioners can buy care from and therefore help people to leave hospital in a timely way. So that's some of the stuff we're doing in the proactive space. In the reactive area, we're continuing to respond to risk. So a large number of our inspections are triggered by risk, and we are acutely tuned into any feedback from members of the public, carers, whistleblowers around poor infection prevention control, any particular concerns about excessive staff movement between care settings. When we get that information in, we're making a judgment and we're going out and inspecting. We're also doing reactive inspections where there are outbreaks in care homes where we have concerns about the spread of COVID, and we're going out and looking at practice in those circumstances. And then a topic we talked about a lot at our last board was around the work around closed cultures and our commitment to absolutely focusing on ensuring that we are responding and regulating to potential closed cultures. So we are ready to respond and looking at work through the next couple of months, particularly about inpatient units for adults with learning disabilities and autistic people where we have concerns of poor quality care or closed cultures. So we will be responding to that in the reactive space during this part of the pandemic, looking at it potentially being a programme period, a programme set of work when we're out of the immediate pressures that we're under. And as with other colleagues who will talk following me in the supportive area, myself, my leadership team, my inspectors will continue to engage in our own internal transformation and our strategy, along with ongoing work with the department and other key stakeholders as well. Thank you, Ian.
Thanks, Kate. Just before we move on, Robert, you wanted to come in.
Thank you, Peter, and thank you, Kate. It's really an issue I know I've raised before, but it links to what you were saying about infection control and indeed closed cultures, which is about visiting care homes. And I wonder what feedback, if at all, we have about consistency in relation to allowing visiting, which I think is the default position, albeit with careful precautions being taken. And I just wondered to what extent you're finding that an over-defensive attitude towards visiting is taking place. That's the first question. And the second is, and what we do about that? And secondly, where visiting is legitimately being restricted or indeed stopped altogether, we are, in effect, are we not adding to the number of places where, per force, not through the fault of the home, there is a closed culture? And I just wonder how we keep track of that in these very difficult times, if we are, and whether that is part of, or we just have to accept that's part of the increased risk in relation to our regulatory activity.
Thank you, Robert. So the issue around visiting and the incredibly difficult tightrope that registered managers are walking around the country on this, I think is, reflects they've got a tough job anyway. And you add in the challenge of weighing up residents' mental well-being of seeing their loved ones with the physical risks to the residents, staff, and then the pressure homes are feeling very rightly from families who are, their desperation has grown and grown and grown over the months about wanting to have access and see their loved ones. So it's the most toughest topic. Our position has remained the same throughout, which is the starting point is we want to see providers making it happen wherever it's safe to do so, but they need to be following government guidelines, looking at advice and a steer from their local directors of public health. And there is a wealth of examples that we've shared where providers are doing this really well. We have been really clear that we don't expect to see blanket approaches to visiting, and actually a very blanket approach could be a potential sign around close cultures, and that may be the very trigger for us to want to go out and have a look at a service. So we are very tuned into concerns where that is happening, and we where appropriate will be responding and going out and inspecting to have a look at what that's meaning for people in receipt of that care. But it's been throughout this, it has been an incredibly difficult tightrope. We want to continue seeing a kind of person-centred approach, and we absolutely don't want to see blanket approaches restricting people having access to their loved ones where it's safe to do so.
Thanks, Kate. So we're moving on to you, Ted, I think.
Yes, thank you. Thank you, Peter. So I'd just like to start off by just reiterating some of the things that Ian said a few minutes ago. Hospital services are under extreme pressure at the moment, brought about by the fact we're at the peak of this wave of the COVID pandemic, together with the winter pressures. And this time of year is the time of peak winter pressures for acute hospital services. And I think it's really important we pay tribute to the enormously powerful work going on at the front line, but also at all levels really in the hospital sector, leadership teams as well, in making sure that services meet the demands being put on them as well as possible. under very difficult circumstances. And I think it's very important we start by understanding that, and everything we're doing as a regulator is one to identify safety concerns and taking action where we find them, but equally trying to support these services is working under incredible pressure at the moment. And I think it's important that we are doing both at the same time. And I just pay tribute to the teams that I'm working with, that they are balancing that really very effectively, and they are very focused on providing support, but equally calling out safety issues as and when they find them. In terms of proactive approach, Kate was just outlining the work that ASC are doing on building capacity within the social care sector, and that reiterates the importance that we've talked of many times before of the links between hospitals and the healthcare system and the social care system. And COVID, if anything, has brought that to the fore. And the work that Kate and her teams are doing in freeing up capacity in the social care system to allow hospitals to patients to be discharged from hospital is enormously important in freeing up some of the pressures on hospitals. So that has been really valuable over the last few weeks. We're also supporting hospitals in setting up new facilities such as Nightingale hospitals and other facilities where patients are being stepped down so they can be discharged into those facilities as well. During the COVID pandemic, we're continuing our reviews under the Mental Health Act. The board will be aware, we've talked before about the virtual approach that our teams have developed, which has been very successful throughout the pandemic, and that is continuing during this peak of the pandemic, and we will be continuing that going forward. In terms of reacting to risk, we are monitoring services very closely, and we're working with our partners in NHS England and Improvement to make sure that we understand the risks that they are seeing, both nationally and regionally. We are analysing the data that we have access to in terms of performance data, so we can see where trends are developing that may indicate risks. We're looking at safety reports, and I emphasised in a public statement the week before last the importance of staff raising concerns and reporting safety concerns when they see them, despite the pressures of the pandemic. One, so that we can react to them, but equally it's important that there's honesty about the problems everyone's facing. And I think one of the things that's really important is that we tell the true story about what's going on in the front line of the NHS. And I'm very pleased that staff have been speaking up to us and to others about the concerns they've been finding. I think that's really a very valuable role. We are listening and we'll respond to concerns that are raised with us. Where concerns are raised with us, we initially try and seek assurance from the provider or from the system supporting the provider to avoid doing unnecessary inspections. But where necessary, we are doing inspections in response to risk, and we're taking action where we find issues, safety issues in providers. And we're continuing that reactive inspection going forward. Where we do find issues, we're working with, again, partners such as NHS Improvement to make sure the support is provided to those services so that they can drive rapid improvement. We are focused on what we knew were already risks, and we've talked already about infection vector control. We're monitoring that very closely and inspecting where necessary if we believe there is evidence infection vector control is putting unnecessary risks in services. We're monitoring very closely the performance of emergency medicine services, emergency departments across the country. These at this time of the year are under enormous pressure anyway, and we have talked in previous years about concerns about the pressure in terms of ambulance delays and crowding in emergency departments. And of course, those are exacerbated with the pressures from COVID. One of the real distinctions between this peak of COVID compared to the spring peak is that emergency department attendances have gone up rather than down. And so pressures are very different in that regard going forward. And we're monitoring that carefully. And where necessary, we're inspecting emergency departments and taking action where they need to improve. We're also, of course, focused on other known risks. We're continuing our inspections of mental health services if we find problems. Kate's talked about closed cultures, and we are likewise focused on identifying closed cultures and inspecting where necessary. And of course, I've expressed before to the board my concerns about maternity services, and we are monitoring that, working with partners, but also undertaking inspections where necessary. In terms of our supportive approach, this is very much working with partners in NHS England and Improvement to make sure that we're coordinating our approach. One of the things we really focused on, and one of the things providers have asked us to do, is to reduce the information demands on providers. So they're not getting separate requests for information from us and from other stakeholders, such as NHS England. And we are working very closely with NHS England Improvement on that to try and make sure that we are not duplicating requests for information, and I'm discussing with them how we can develop further transparency so that all our communication, all their communication with providers is shared, so we don't have to duplicate it in any way. The other important area we're working with is making sure that systems have guidance. We worked with NHS England on guidance around their staffing, which was released at the end of last week, which we endorsed and assured providers that that guidance was something that we'll be taking into account when we're inspecting on their staffing. And where other guidance is necessary, we've encouraged NHS England to develop it and to involve us in that process going forward. So we're doing a maximum we can to support services going forward, and we'll keep focused on this as things develop over the next few weeks. I think it is very likely the pressure on hospitals will continue for several more weeks yet, despite the fact that we may, at least in some parts of the country, get beyond the peak. But having said that, the pressures are very high. The numbers of patients with COVID in hospitals are at record levels. And so the pressure will continue for some while.
Thanks, Ted. But just before we move on, Liz, you want to come in?
Thanks very much. Thanks, Ted. I just wanted to ask about one area of risk, which is deferment of treatment, surgery, etc., for people, for non-COVID people. And I just wondered whether we're picking up, on what basis are these decisions being made? Fully understand the difficult decisions that services have to make. But are we confident that that these decisions are being made sort of fairly and sensibly and as safely as possible? And secondly, that people have sort of communication if they're on long waiting times like that, and they may have worries about cancer or whatever else.
Thank you, Liz. And I think that's a really important point. I should say that when we're monitoring risks, we're monitoring risks in non-COVID and COVID services. We're not just looking at COVID services, and non-COVID urgent services are equally a focus of our attention. The work we talk about emergency medicine affects both, and I think it's important we are not focused purely on COVID services. There is some good guidance out there and work with NHS England around prioritisation for people with very urgent non-COVID conditions. And talking to providers, I'm reasonably confident that they can provide the care within a timely way. I think there's more concern about people with less urgent conditions. And there's no doubt with people with less urgent conditions who are waiting for treatment, there is a big backlog developing. And I think our focus going forward, and this is work we need to do with providers and with our partners, is to make sure that those patients are followed up effectively. They are given paths of escalation if they believe their condition is deteriorating, and the risk is monitored as the system catches up with the backlog of work going forward post the pandemic. I think a lot more work needs to be done on this, Liz, but we are very much engaged with talking to providers and our partners to make sure that it's followed up effectively.
Mark Saxton.
Thank you, Chairman. Thanks, Ted. Really good to hear from you in terms of us continuing to monitor safety with hospitals who are reporting staffing, oxygen usage, ambulance waits and bed capacity challenges. Good to hear that. Just would like to hear from you, if we could, about the challenges facing frontline health service workers in terms of their mental health. And I wonder if you could just help us to understand how we will continue to focus on this area in our well-led key lines of inquiry. If you could just talk to that a bit. And second question I have is about how we are monitoring the provision of other critical hospital services such as cancer and stroke services.
Okay, thank you, Mark, for that. The frontline staff are under enormous pressure at the moment. And for instance, in intensive care units, traditionally you'd have one intensive care nurse per bed in an intensive care unit. That is being stretched in current guidance up to 1 in 2, 1 in 3, 1 in 4 in some cases. And the staff coming in to fill the gaps are not intensive care specialists. They're working, if you like, from other parts of the hospital to support the intensive care nurse who's leading the team. And these staff are not used to working in that environment. So for these staff, I think working in intensive care, dealing with patients who are particularly difficult with in major respiratory demands in terms of their care, I think is really challenging for them as individuals. But the sheer weight of work, I think, is challenging for everyone because the weight of work is relentless. I've heard that word used a lot recently. And I think it is really difficult for staff. As I said a few moments ago, this is going to go on. This has been going on a while, and this will continue for a while. So this goes on and on for staff, and I think it is putting enormous pressure on their sense of well-being and their potentially their mental health. So this is going to be really important going forward. And one of the things that we've identified in our review of well-led is the importance of staff well-being as at the centre of the leadership culture of organisations. And I think that's something that's come to the fore enormously over the last few years as we've been developing our inspection methodology. So staff wellbeing was and staff culture was already a very strong part of our well-led assessment. But I think you're right, it's going to have to be an important part going forward in the response to COVID. And I think that is the real challenge. We're developing a new well-led assessment framework, as you know, and we're going to build staff well-being into that really strongly, and the culture of supporting staff into that really very strongly. And there are going to be lots of elements of that. One of the things that I think is really important in this is that honesty I was talking about a few minutes ago about the problems at the front line. And I think there is a tendency sometimes for the kind of external communication about healthcare to be very positive, when people at the front line can see the reality, which is sometimes quite challenging. And I think that disconnect between frontline experience of healthcare and the kind of image of healthcare is, I think, sometimes very difficult for frontline staff. And I think that honesty, giving them the freedom to talk about the things they're concerned about, is really important going forward. So these elements of culture are going to be central to our well-led assessment framework going forward, and we're building them into our transitional monitoring app approach to well-led, which we'll be developing over the next few months. So assurance to you, this is going to be really important in our well-led assessments. Mark. And in terms of the safety in other services, as I said to Liz a few moments ago, we are monitoring safety in all services, not just COVID services. And it's really important that we do that. I think one of the differences from managing this peak of the pandemic compared to managing the previous peak of the pandemic was there's been much more focus on keeping other services actively going. And I should say, to any members of the public who are watching this, it is really important that people who have concerns about urgent conditions do seek care from the NHS. The NHS is very much open to them. I was in a hospital yesterday and they were talking about their COVID care, but they were also talking about the level of care they were providing for people with other conditions and how much they were focused on that going forward. And I think that is really important going forward, that people recognise that care is available. We will certainly be monitoring risk across all healthcare groups. So we'll be looking at risks in cancer services and in cardiac services and in stroke services, renal services as well, to make sure we are identifying risks in all those services as they develop, and we'll intervene in those as necessary.
Thanks, Ted. That's really good to hear. Thank you.
Thanks, Ted. Rosie, we'll move on to you. Please.
Thanks, Peter. And can I just pick up a couple of extra points with Liz and Mark's questions there? One is about the backlog and the large waiting lists. That is only going to be tackled if there's a system-wide approach to it. It's not just a hospital problem. The impact will be felt right across the system. And as the integration board has started doing some work understanding how we look at that, and particularly the primary secondary care interface. So that's something that we're very much attuned to and very much looking at as a system-wide issue, and the recovery of those within the waiting lists and recovery of that will need to be tackled at an ICS level and a system-wide level if real progress is going to be made. And the other thing, just to Mark's point about staff wellbeing, is that we have picked up a huge amount of really great innovation in our provider collaboration review in terms of how systems are supporting the wellbeing of their staff and what they've put in place. And certainly some of that was in our state of care report with the last set of provider collaboration reviews, and with the urgent and emergency care reviews. Again, we have picked up some really great practice, which we will be sharing with our urgent and emergency care PCR report. So systems are finding innovative ways to actually look at supporting staff wellbeing, which is fantastic. So just if I could run through each of the different sectors in PMS. In general practice, we are taking a reactive approach. We are aware of the enormous pressure in general practice at the moment. GPs are having to deal with both increasing demand with the normal winter pressures, plus seeing people with COVID and the after effects of long COVID and other problems, plus an increase in mental health problems due to the effects of the pandemic. And on top of that, they are also successfully rolling out the primary care vaccination programme and doing a fantastic job with that. So I just want to say thank you to all my colleagues working in general practice at the moment, because I think it's a very challenging time, but they are absolutely doing great things, particularly around vaccinations. So we are taking a risk-based approach in general practice. We are only inspecting where there is very high risk, and we are doing as much as possible of that off-site. We can access clinical records, we can access a whole variety of things off-site, and we want to minimise the impact that we have. We are also monitoring areas of high risk, breaches, areas of concern, and doing that in conjunction with partners such as clinical commissioning groups, working with local health watch and other partners as well, which gives a huge amount of information. In terms of the primary care vaccination programme, we're not planning an inspection programme, but we will be following up risks with the vaccination programme. Primary care, as you're aware, are used to running vaccination programmes, and they do the flu vaccination programme. It's very different in lots of ways, but there are lots of similarities. So it is something that our teams are very used to looking for and looking at how vaccination programmes are delivered. So that's something we will be following up. In dentists, we're following an inspection programme only where we identify significant risks. The TMA approach has been welcomed by dentists and felt to be supportive and helpful in terms of signposting to guidance and other things. And we are particularly focusing around access and sedation in dental providers' access, because we know that there is a huge backlog again of dental treatment as a result of the pandemic on sedation, because that's a high risk area in dental practice. In independent healthcare, we are looking at particularly high-risk providers, and also providers where we've never inspected them, because we are unaware of the risks in those providers. So those are our priorities in that area, and inspecting where we find high risk. We're taking a proactive approach with our sexual assault referral centres, with our health and justice team, because there's been concerns about the hidden sexual abuse and increasing during the pandemic, and we want to make sure that people get good care with that. And we're also working closely in a reactive way with Her Majesty's Inspectorate of Prisons around prisons, and making sure that we are monitoring what's happening in those and taking action as necessary. And finally, just to mention, we're taking a proactive approach with SEND visits, the special educational need visits with Ofsted, because we are very conscious that children and young people with special educational needs and disabilities, there has been concerns about their care during the pandemic, and we've wanted to make sure that they continue to get good care. And we're also continuing to inspect children's residential care. Sorry, my final point is around provider collaboration reviews, which are really looking at how we can find and pick up the good practice and share the learning around COVID, we have decided, due to the high level of pressure in the system, to postpone our cancer field work. We've done all of the work behind the scenes, and we are continuing to engage with a lot of the cancer stakeholders, but the actual field work we've postponed, and we're looking to reinstate that as soon as we possibly can, because it does go to some way to answer Liz and Mark's question about the care for non-COVID patients. And we're also behind the scenes preparing for our learning disability PCR, so that's underway as well.
Thank you, Rosie. Robert, you wanted to come in.
Thank you, and thank you, Rosie, for that report. My question is about the vaccination programme. And as you said, this vaccination programme is a different scale and a different order to anything that's happened before. And the question I don't want to is how you assess risk and what sort of information you get about risk in relation to these brand new sort of vaccination centres, bearing in mind the huge variety of locations in which these are being set up. And I just wonder to what extent we look at the consistency of practice in relation to infection control. You're gathering crowds of sometimes very elderly and vulnerable people, and I've seen one of these in operation, and it's hugely impressive what happens. But on the other hand, then there was a queue of people in the street outside, and you just wonder how that's working. And I just wonder what our remit is actually in relation to what is, half public health, half GPs and half volunteers. Well, not half, that's bad mathematics, but you know what I mean. And quite what our role can be, apart from being supportive.
So if I could just explain what's happening in the primary care sites, and then maybe Ted and Kirsty would like to join in about the mass vaccination sites and the work we're doing in registration around this. So in primary care, a lot of the things that we look for anyway with vaccination need to be in place, such as emergency drugs and defibrillators and the correct kind of oversight of the staff that are giving drugs and vaccines. So that is things we already look for as part of our inspection programme anyway, and we're already looking at that as part of our monitoring of providers to check that those things are in place. The CCGs have a critical role to play in the vaccination programmes with primary care, and they do a lot of the assurance visits themselves in terms of making sure that the vaccination sites are set up and that they've got the correct handover facilities with the vaccines themselves and all of those logistical issues. And so the CCGs have got an assurance role, and we're working closely with them to make sure that we don't duplicate, but what we do is actually complementary. And so we are having regular conversations with the CCGs. Risks are being fed through to us, and if there are concerns about how vaccines are being delivered, then we are following them up. But I think there's assurance levels in other parts of the system, so we are working in partnership with those places to avoid duplication. But Ted might want to comment on the mass vaccination sites led by trusts.
Yes, thank you, Rosie. So in terms of mass vaccination sites and those sites run by NHS trusts, we are using a modified version of our transitional monitoring app called the Vaccine Monitoring App, which we are contacting them all and going through a series of assurance questions with them to make sure that they have the essential safety assurance in place operating. We anticipate that to be relatively straightforward for them. We're not looking to put any undue demands in any way that will hold up the vaccination process, but we do think it's essential we make sure they have the basic safety measures in place. Clearly the vaccine itself, vaccination itself is relatively low risk, but when you're vaccinating 50 million people, relatively low risk could be quite significant.
Yeah, thank you.
Kirsty, do you want to come in?
Yes, sorry, thank you. So just in terms of the registration piece, we're part of a cross-sector working group with NHS, Department of Health and Social Care and other regulators such as MHRA to look at a sort of more proportionate approach to regulation in terms of how we do that. as Ted said, these are have been registered as sort of sub-locations of hospitals, so that we're able to check those as part of that registration. We've been prioritising that activity to ensure that regulation doesn't become a blocker to effective operation around these.
So I think each of the chief inspectors paid tribute to the work that's going on the front line, but I think we should also pay tribute to the work that our own colleagues are doing. I mean, you just heard the massive amount of activity and difficult circumstances for everybody. So just publicly on behalf of the board, I'd like to say thank you very much to our own colleagues.
Thanks, Peter. So should I move us on to part 2 of my report?
Yes, please.
It'll be very quick, I promise. Just 2 very quick things from me from part 2 of the report. Firstly, just to let the board know, I'm continuing to work with my opposite numbers across the UK and the Republic of Ireland. And we're doing a series of pieces of work just to share experiences, really, and that's been a useful conduit all the way through this, all the way through the pandemic, and that continues. And we're working alongside our government policy colleagues as well, just to make sure that those channels are also open. Just a point of detail, COVID testing as an activity is no longer a regulated activity. So there was a change in December, a legislative change, and that's meant that we don't now need to register those testing sites, which I think is probably a good thing. So that's all I wanted to say. If I now hand over to Kate for her section. Thanks, Kate.
Thank you, and I will be brief as well, as I've covered the infection prevention, control and designation scheme update during the priorities conversation. So if I just briefly mention closed cultures, really focused discussion on this agenda at the last board following Professor Glynis Murphy's findings. Just wanted to let board know that Debbie Ivanova, Deputy Chief Inspector in my area, going forward for the next 12 months will be providing a cross-organisational leadership around the issue of learning disabilities and services for people with autistic people. So she'll not only be looking at services in adult social care, but she'll be looking at things such as access to annual health checks within GPs through to inpatient units. And the starting point for her focus will be around inpatient units, as that's where we're currently concerned around risks around closed cultures. So for next board, Debbie hasn't officially started just yet, but for next board we will have an update on what that programme of activity looks like that she'll be taking forward over the next 12 months. So that's all I wanted to say for my update. Thanks, Peter.
Thank you. So, Ted, I think we're on to you.
Yes. Well, I've covered most of what I wanted to say in the section on priorities. Just a couple more points from me. I think one thing that has become very clear during the COVID pandemic is that a lot of the risks we saw in services before COVID, if you like, were brought to light and highlighted by COVID. For instance, critical care services are one of the services that have always scored most highly in our inspections, and they have really responded magnificently well to the pressures of COVID. It is dramatic what they have achieved under enormous pressure. I was talking to a hospital this week that normally runs 70 critical care beds. It has gone up to 200, sometimes over 200 critical care beds, a dramatic increase in critical care facilities from a service that is under enormous pressure, but we have rated very highly up till now across the country fairly consistently. Well, another service such as emergency medicine, which despite the hard work of everyone at the front line, and we recognise that, every winter has been under enormous pressure, again, is finding it very difficult. Now, I suppose it's disappointing to some extent that we have been highlighting this issue, working with our colleagues over the summer, the importance of preparing for the pressures of COVID and the pandemic. And I think what that COVID has demonstrated is that the structural problems we see in emergency care need to be addressed if we're going to be ready to deal with a normal winter as much as a COVID winter. And I think that to some extent is unfinished business. And we will be continuing that work with emergency care colleagues going forward, because I think a real consensus has developed around that over the last few months as a result of the pandemic. Two other areas we're looking at. We mentioned earlier on about recovery from COVID and recovery of other services, and we are doing work with providers to explore what best practice would look like, and hopefully we'll be able to provide some support and guidance as that goes forward. And we've also set up a risk summit around maternity services, which I hope will be either towards the end of this month or next month, to set some momentum into the improvement in maternity services that I've called for previously. While maternity services are not at the centre of the COVID pandemic, although they are involved to some extent, I think it is really important that we keep the momentum up in improving safety in maternity services, and we will continue that work going forward with providers as we go into the spring. Thank you, Peter.
Thank you, Ted. Nobody wants to come in, so Rosie, we'll move swiftly on to you. Please.
Yes, very quick update from me, just to say that the Do Not Attempt Cardiopulmonary Resuscitation Review is very much on track. We have finished the field work now in the 7 CCG areas, and we are now analysing all the information that we've got, and we are on track for delivery of a report to be delivered to ministers at the end of February.
Great. Gosh, everybody seems to have gone very silent. So take that as a positive. Kirsty.
Thank you, Peter. So just a sort of short bit from the People Plan update this month. So we have been reviewing our policies over the last 12 months. These are sort of overall HR policies to make sure they're being brought up to date and ensure that they're fit for purpose. In December, we launched 3 new key policies: managing sick absence, critical illness, and conflict resolution. These and as well as alongside these, we've put together a training pack to ensure that we have a consistent and good application of these policies to ensure they land well. So that's been really positive. As part of this work, we to ensure that our policies are as inclusive as possible, we have external review with Stonewall and the Business Disability Forum, and I'm pleased to say that we've now been able to bring Mind on board with that process as well, to ensure that we really are considering the impact of our policies from as wide a perspective as possible. So that's all I wanted to say in that area. Thank you. Chris is going to pick up the performance piece. So Chris, over to you.
Thanks, Kirsty. So this is the performance report for November. So there's a one-page, for the benefit of new members to the board, there's a one-page dashboard in the annex. On a quarterly basis, there'll be a more in-depth pack. So that'll be next month for the Q3 report. We'll also look to how we can cast this based on the 3 priority categories that we referenced earlier. So just a few areas to pull out from me, keeping it brief. Registration, so we continue to track the simple and complex applications, which is work we've been doing in year to change how we look at our KPIs. Simple applications are taking on average 24.2 days to process, with complex taking 114 days on average. But as mentioned before, the team are continuing to prioritise applications that support the system's response to COVID. In terms of safeguarding and whistleblowing, we aim to action 95% of safeguarding actions in 1 day, currently achieving just over that 97%, and also aim to action 95% of safeguarding concerns in 5 days. We're currently just under that 94%. In terms of regulatory action, between April and November, we inspected 3,250 locations, and if you exclude thematic inspections, 80% of those inspections were the site visit were conducted due to risk, with the remaining being prioritised due to risk, for example, breaches of regulation. Alongside that, inspections continue to be mainly triggered by information of concern or statutory notifications, for example, whistleblowing or safeguarding concerns. Last bit from me, just on our money. So our revenue budget is forecast to be 10.7 million underspent by the end of this financial year, which is just under 5%. And our capital budget is forecast to be 0.2 million underspent for the year. So happy to take any questions on the report.
So, Peter, Can I just add in? Sorry. So just in terms of, I know we've been having conversations with Mark around the people metrics. I just wanted to assure him that the next report, which will be the quarterly report, there will be a much more detailed deep dive into our people metrics. I thought I'd just answer that question before it gets asked.
Very good.
I feel I had to respond, Chairman. Just to say, Kirsty, thanks very much for that. And yes, I had a very, very good meeting with Jill and with some members of the People Directorate. And what we're trying to produce is some more people information that sort of highlights joiners, leavers, promotions and temporary transfers. Shines a light on our D&I data, our training and our well-being of our people. It gives a chance for all of us to, look at that data and interrogate it as we want. But thanks very much, Kirsty. It was very good. And I did ask Jill to come back to you and get it signed off by you.
Great. Chris, I know the answer to my question, but I'm going to raise it anyway. I mean, November seems an awfully long time ago, particularly this year. I understand why there will always be this sort of lag because there's a lot of data to pull together. But if something was going seriously wrong, if a wheel was coming off somewhere, I just would like your assurance, the ET's assurance generally, that collectively that A, we would know, and B, it would be brought to the board attention. We wouldn't wait until the following month. Absolutely.
It is an unfortunate lag, but obviously, yes, we would flag anything urgent, and the executive would have seen kind of just getting into the month ahead. We're just finishing off the December report, so yeah, absolutely would flag anything.
So the absence of anything being flagged is a positive. Yeah, yes. Excellent. Good. Thank you. Ian's nodding as well. Thank you very much. Right. So I think we move on. Mark, to you.
Yes, and I'm delighted to report again. No any cybersecurity issues to report this month.
Perfect. I love your reports on that. Chris.
Hi, so I've got just a couple of things to go through from my perspective. Firstly, just to talk a little bit about the strategy feedback, just to give a sense of where we are. As you've probably heard from all the conversations that we've had so far, there's never been a more important time to CQC to ensure that it's going to be effective in the future around how it delivers its regulatory activity. We've been, as the board knows, over a number of months, we've been having conversations with people who use services, with providers that we regulate, with our own colleagues and with other stakeholders to understand how CQC needs to improve and change what it does to be responsive, not just because of COVID, but because of the other challenges around how we provide timely information to people. The latest round of engagement, just prior to the end of the year, we've met with a mixture of groups. So in terms of the public, over 5,000 public group stakeholders and individuals. In terms of providers, we've met with recently with about 7,500 providers of different types, as well as colleagues internally across all aspects of the business. The logic of doing that is to continue to test not just our thinking, but some of our approach to how we might change. And I have to say, some of the conversations have been very positive. Ian this week came to an overarching group which is made up of people who use services, providers and other stakeholders to talk through all of the strategic themes. I just wanted, if I may, just to give a couple of nuggets of information on each of the four themes and the important feedback we've had from different groups. In terms of people and communities, I think the challenge about how we weight the voice of people alongside the voice from the sources and how we make sure we can provide an open and honest account of what is going on. There's a strong support which bleeds into smarter regulation for real-time information, real-time updates on what people have said. But smart regulation itself is, again, a lot of support for an increasing emphasis on providing information in a more real-time way, with our ambition of making more data and information available. And the challenge is how you make that meaningful to all groups, so providers, so that they can learn and drive their own change, and so the public can be informed about choice. In terms of safety, there's a really strong emphasis on learning, and I think both from the conversations we've had with providers and from public and other stakeholders, the ability to move to a situation where people feel able to support or able to speak up about issues needs to be driven from all organisations to the point of this is about the learning that organisations and the learning journey that all organisations, how you create a positive environment for learning even in these difficult times, as well as being clear about what it means to be safe and having that good conversation with frontline clinicians about what it means to be safe. And lastly, around accelerated improvement, recognising there's different coalitions in different sectors, but how we use what we now have, the really powerful information that we know, both from our inspection activity and our other data that we hold, to drive and accelerate the right improvement in each of the sectors, and as Rose mentioned earlier, across sectors. So this is not just about individual organisations, this is also about how individual organisations work together. So just to give the board an assurance that conversation is ongoing. We'll continue those conversations as we move into the implementation of each element of the strategy.
Thanks. Stephen.
Thank you, Peter, and Chris, thank you very much for the update. The question I just wanted to get your view on is, as you're developing the strategy, how do you see it potentially needing to flex and adapt as we learn the lessons of the pandemic? Because we've got a really major system change and development going on in real time now, and we're trying to develop a strategy for the organisation. And at some point, these need to keep sort of iterating and talking to each other so that the strategy is informed by the learning from the pandemic. How does that work?
I mean, in a sense, that's exactly that is exactly the most important point. What's really been helpful over the last year, as we begin to think about the themes of the strategy, through the testing we've done as part of the pandemic, we've been able to hone our thinking around what it might mean to, for example, use data and information to drive our view of inspection. Ironically, I think that the pandemic has helped us test some of those, the reality of that in live, and give people and providers, people who use services, a sense of what that might mean. But it does rely upon really strong feedback. So we've been really working with the TOO programme around the implementation, really feeding back from people who are experiencing those services and experiencing the changes that we've made about what's worked. So what's worked around our transitional regulatory approach, what hasn't, what people like, what they don't like, so we can feed into that work. And I know from the colleagues that are involved in the next stage of this, that really important feedback is guiding our view about, for example, how we develop, and Mark's talked about it earlier, how we develop our new platform for how we develop and share information. So people who use services, providers, and importantly our colleagues have helped shape how that should work. I think there's more work to do with that. I think there'll be more conversations that we need to have, and I think the more we can keep it to real time and iterative views. Although the strategy has a sort of a 5-year timeline, this will iterate for me over a period of time, and I think we shouldn't be afraid of allowing it to iterate. The great thing about the technology platform that we've got is it allows for that iteration. It allows for those changes that we make as we go through this year into the next. But it's a really important feature that we can hold ourselves accountable to the changes that we make over time and explain why.
And I think just to add to that, Chris, Stephen, from the outset, we've recognised that there will be an awful lot of other changes. Just give one example, we don't know at this time how ICSs are going to develop. And we have to have a 5-year strategy that is able to adapt to whatever comes along. So in a sense, that's been integral even in our thinking even before the pandemic arrived.
Yeah.
It's a really, really strong point though. Good. Anything else on the strategy for today?
No, I wasn't going to do strategy. I've just got a couple of things to go through. If that's okay. As part of our stakeholder engagement, we regularly engage with, obviously with DHSE, with ministers, and also with opposition groups as well. So as part of that ongoing engagement, we've recently met with colleagues from the Labour Party, again to talk through the strategy. I think it's important that all sides of the House understand what we're trying to do and why. Rosalind, who we met recently, is a frontline A&E doctor, so she understands the front line of the pandemic. Her particular area of responsibility is mental health, but there was broad support for some of our thinking around our intentions around the strategy, and I think it's important that we can keep all parts of the House informed about what we do, so that they can understand the relationships about how we're changing over time. We regularly get correspondence with north of 100 MPs, so there is an ongoing dialogue with a number of groups. I just wanted to make the board aware that we'll continue that dialogue alongside the wider stakeholder dialogue that we have with groups that work alongside us and those that we regulate. And then the last thing, just sort of to tidy this bit off, and Sir Robert already mentioned this about the voice of people who use services and frontline clinicians. The give feedback on care, the latest spike in that is due to be underway shortly. Spikes 1 and 2, that we focus on different groups where we want to hear from individuals, particular individuals we think might be underrepresented. We've seen a 21% increase in the information received by telephone, because some of the information comes in that way, and a 61% increase in the care received by our new dedicated Give Feedback on Care web platform. The key thing for me, this is allowing us to do more responsive inspections that are responding to that risk, both from people who use services, but also from frontline staff. And I think just to sort of talk to Robert's point of earlier about how can you be assured with closed cultures, well, actually, I think the fact we're hearing more from frontline staff is to be encouraged, and carers and people who use services as well. And I think it does give a lens. It's not a panacea, but I think it does give a lens. The key thing for me is about how people feel that we are responding to their requests. So I think the fact we're doing more responsive inspections is really, really important, and that trust that develops from how people give that feedback and how it's responded to will be something that we take into our thinking on the next strategy.
Great. So I think, Ian, that completes the executive team report. We're happy to move on.
Yes, thanks, Peter. Yes.
So, Chris, we come back to you on the insight. I think these insight reports have been a really valuable contribution to understanding what's going on through the pandemic. So what I'm about to say does not in any way take away from the importance, but given that these are really to aid in understanding, and both members of the public and our various stakeholders and ourselves can all read that, I'm kind of hoping we can be fairly quick on a board discussion on this particular insight report.
I've got that subtle nudge. What I would say is, I think just to say a couple of things then. These reports are designed to partly to share what's gone well, partly to understand and help learning in the system and in organisations. So the issues that we talked this time around bed occupancy in designated settings is designed to give us a view about how different areas are responding to the issues around moving people from secondary care out of secondary care into either home or into adult social care, to give both regional people responsible regionally, but also people responsible nationally, a sense of what's working and what isn't. And alongside that, we continue to provide data and information that we know that people are looking for as think tanks and others begin their work, and hopefully provides a useful contribution to the debate about how services need to change and improve. The particular exploration of deaths in adult social care has been an important topic for us, and I want to make sure that we're able to openly describe what we think is happening in different areas. I'll therefore forgo the longer version of that I was going to go through, but I'm very happy to take any questions. Just to say, Ian's joined us, Ian Dodds, who's the editor of that document.
So absolutely, I was not to stop people asking for questions or clarification or anything else. And Robert, over to you.
Courting popularity as usual, Peter. Thank you. Just one question. I mean, firstly, of course, these reports are extremely useful. This one ends with prompting a question, really, which is the analysis doesn't explain why people from BME groups or those with a learning disability and autism are more likely to have died from COVID. Which prompts the question, who is seeking to find that out, and you know, in what sense can we contribute to that? What clearly needs to be a further investigation.
Right. So there is some ongoing work with the ONS to look at this in more detail, and with other organisations as well. And part of the reason to put this out at this point, Robert, is just to make the point that the data doesn't lead you at the moment, lead you one way or the other. We thought it was important to be open about what we know at the moment, and almost to be clear that there wasn't already a sort of a smoking gun, as it were. But the work we'll do with the ONS and with other organisations, DHSC included, I think will help hone down on what the issues that lie behind that. There's some work around social deprivation in different areas, and whether there is a link in that way to death. So we wanted to be clear, but we wanted to be clear also where there wasn't a definitive answer just from our information.
Thanks, Chris. Does anybody else want to raise anything? Or have I successfully put you all off from? Great. Oh, that's really good. So we get back onto track time-wise. But Ian Dodds, thank you very much for the work that you do on this, because I really do mean what I say. I think these are really, really important documents, and the information that they're providing, I think, has been hugely important to understanding what's going on. So thank you.
Thank you, Peter. That's very good to hear.
Yeah, thanks, Ian. So let's move on then. Liz, I think we come to you and the RGC, which we had a really good meeting last night on.
Thanks very much, Peter. So, yes, we started out in the Regulatory Governance Committee by just taking a look at the risk register, those risks that relate to our regulatory functions. For example, you know, the rapidly changing environment, and how well has CQC been able to adapt, and what risks are there in our own adaptation to that. And we looked in detail at how the executive team had rated those risks, scored them, and the mitigations, and we were satisfied that risks were being identified and acted upon. So that was the first point. We then had a discussion on the project that Rosie's already mentioned on do not attempt CPR. So the stage it's at is that from the field work and surveys, emerging findings have come back. And what we were discussing was really the interpretation of those findings so far, the framing of them, and how could that report be used to make the most difference to improving those all-important advanced care planning discussions and the advanced care planning process, so that, I mean, the findings will be out, as Rosie said, in the next month or two, but just to sort of make sure that we are really thinking about who can make a difference on this agenda, so it's not just a report. We then looked at the transitional regulatory approach, and the vision for this really is that for the inspectors, they would have in one place all the information they need to know about their patch or a particular provider. So that might be not just information that's come from earlier inspections, but also it's issues that have been raised by people using services, or their carers, or members of the public, or members of staff. It would be data that the CQC has and can access about that particular provider, about how it's doing compared with other providers in the same areas, that sort of thing. So it's about creating a much more holistic set of evidence to really improve decision making and therefore improve regulation. So we looked at the detail of this, and we looked at sort of how, through that holistic approach, risk was going to be identified, how there was going to be confidence that risk would be identified, including sort of thematic risks as well as individual risks. We looked at how this approach fitted as against what other regulators are doing in other sectors, and really sort of gave a steer to the executive about some of the thinking of the committee on how to develop this work, which obviously will come to the full board in the fullness of time. So it was a very good discussion. I think that committee gives us the chance to probe in more detail some of these really critical issues in CQC's development of methodologies. Thanks, Peter.
No, thank you, Liz. I'm looking around. Does anybody want to come in? No, I think we all said all we wanted to say last night when we were, or yesterday afternoon rather, when we were in the meeting. Great. So, is there any other business anybody wants to raise? Well, I do. I want to acknowledge, Liz, that this is your final meeting on the board, and to say what an outstanding colleague you have been. You've been a great chair of the RGC, both in setting the agendas, which I think is a really important thing in a group like the RGC, to make sure it's focusing on things that really matter, and you've done that. You have a very nice style of chairing, and you have a brilliant ability to summarise, something which I am totally unable to do. So I admire that enormously. But you've also made a massive contribution in other ways outside the board. Your support for various pieces of work over the time you've been on the board, I know, has been much appreciated by colleagues. And you make great interventions in the board. We're really going to miss you. So just on behalf of all of us, a very big thank you, and we wish you well in whatever you're going to be doing next. So thank you, Liz.
Thank you very much. Thank you very much, Peter. It's been an absolute pleasure and privilege, and I look forward to seeing how the strategy implementation goes. I'll be supporting from the sidelines. Thanks very much.
So you had a round of applause, which you couldn't hear because everybody's on mute, and you had a standing ovation from Ian because I was standing up as we're talking. So that's great. So I think that brings the meeting itself to an end. We have two questions from Robin Pike. By the way, if I'm looking at something, I'm sitting in the dark a bit, it's because the light bulb above me went off just as we started the meeting. So I'm going to struggle to read the questions now. But anyway, the first question, I think, is how does CQC now intend to make all areas of its work more outcome focused and less process driven? Ian, I don't know if you could answer that question.
Thanks, Peter. Yes, I think in a number of ways. This is, I think, linking back to the strategy, but the strategy will focus on putting people and safety at the heart of what we do, and that's written all the way through the strategy. The transforming our organisation work will try and make a reality of that, so that we organise ourselves in a way that is focused around particularly geographical outcomes, and the big theme around smarter regulation is an important way of making ourselves less process driven. And in our people theme, the first theme of the strategy, we talk about our regulation should be driven by people's experiences and what they expect and need from health and care services, rather than how providers want to deliver them. So again, that's a clear indication that as we do the work that we're doing on redesigning our methodologies for the future, that will very much be at the heart and the starting position of our thinking. And the communities and inequalities focus, again, that runs all the way through the strategy, again, make sure that we're going to focus on outcomes for people and local populations, and how providers are working together to improve them. So I think there isn't a very simplistic answer to this question, but it's a multifaceted response. Thanks, Peter.
Thank you, Ian. And then the second question from Robin is, during the recent holiday period, NHS 111 came under pressure. I think it's been under pressure actually for quite a long time in one way or another. How did CQC assess the performance of these services during the holiday? Rosie, perhaps you could comment on that.
Yes, and I'm hoping you can hear me and see me because my internet's causing all sorts of problems today. So we do this in a variety of ways. We look at the SITREP data from NHS England, and if there's any concerns about that data, we take appropriate action to explore further. We are also running the TMA process with providers of 111 services, and we will continue to do that, and particularly in those providers where we're concerned about any risk. We work very closely with stakeholders at a national and a regional level to make sure that we've got good visibility of what's happening, and also we do that at a local level, so we understand how the system is working and what the pressures on the system are. We've also finally been looking at 111 in the recent urgent emergency care provider collaboration review, and we found some really innovative approaches to how 111 is being supported, so we will be sharing those findings soon.
Thank you, Rosie. And there are no other questions from the public, so that is the end of the meeting. Thank you all very much indeed. So just before we all go, we have miraculously now got ahead of ourselves on time. So we have a choice. We can either have the Omni project demonstration at 1:15, if people would prefer to get back onto a slightly earlier finish, or we can stick to what we said and we do it after the end of the meeting, which would be about 2 o'clock. So an hour for lunch or 45 minutes and an earlier finish. Any strong views? God, dear, right. So let's in the absence of anybody saying anything different, let's stick to what we said. We'll do it at the end. So we've now got ourselves an hour to go and do other things, and we'll be back promptly at 1:30, please. Thank you all very much.